Hello, doctor. Welcome back to ICU Academics. Today we are tackling one of the most debated questions in critical care, non-invasive ventilation, NARDS. Is it a savior or a setup for failure? This is what we are going to discuss today because we know that ARDS is a battlefield where every breath counts. On one side, NIV promises to spare the patients the risk of intubation, preserve airway reflexes, and buy precious time. On the other hand, evidence warns up for high failure rates, delayed intubation, and worsening outcomes. In this session, we will break down the physiology, examine the evidence and landmark studies from early CPAP trial to the lung safe study, and distill the exam ready points for EDIC and Saudi Board candidates. By the end, you will know exactly when NIV can be a friend and when it becomes a dangerous enemy. So these are our learning objectives that we are going to define and discuss the pathophysiology a little bit very briefly. Then we will discuss the rationale for using NIV in ARDS and critically appraise the evidence supporting or opposing the NIV in ARDS and identify patient selection criteria for NIV success. So ARDS is a diffuse alveolar damage. It is the inflammatory disorder and that leads to impaired gas exchange through the alveolar capillary membrane. And because of the flooding of lung parenchyma, the lungs becomes wet, heavy, and compliance reduces. And that put the patient into difficulty in breathing, respiratory distress, high work of breathing, and simultaneously they develop hypoxemia because of poor gas exchange and VQ mismatch, etc. That is the hallmark of ARDS. Later on, there is a risk of ventilator-induced lung injury if the patient is intubated. Okay, so this is where NIV has a rationale to avoid the intubation. So we have four options. Either we can put a patient on SOT, that is standard oxygen therapy using the nasal cannula and face mask and RBM, etc. Or we can put the patient on the latest technology, which is high flow nasal cannula, HFNC or HFNO, to improve the oxygenation and to give the comfort to the patient. And third, non-invasive therapy, as we are going to discuss today, is an IV non-invasive ventilator. Okay, that can improve the oxygenation and reduce the work of breathing. So till these three respiratory supportive management, we are not intubating the patient, right? But suppose things do not work well in time and patient becomes more tachypneic and does not improve at all, then we have to go for intubation. So this is the last respiratory support, invasive mechanical ventilation. So the role of NIV is just to avoid intubation because we know there are some risks related to invasive mechanical ventilation. The biggest risk is to intubate such a patient, which can cause hypotension, cardiac arrhythmias, airway trauma, and later ventilator associated pneumonia and critical illness polyneuropathy even if patient comes out of ARDS. So all these things are the risks of or complications of invasive mechanical ventilation, which everybody wants to avoid. Okay, and that is the rationale, big rationale of using an IV in ARDS. So it avoids the intubation and in complications related to intubation. The second important rationale is that it preserves the airway reflexes. NIV preserves the airway defenses, cough, swallowing, everything is intact. And patient can be the master of his own breath. And it has been seen that using an IV in ARDS can reduce the ICU stay in the selected patients, and it can be used as a bridge therapy, just a trial before invasive mechanical ventilation. So these are the four important reasons why we use an IV in ARDS. Okay, so now we know the reasons or rationale. Now we will talk about the evidences. So early studies created optimism that NIV could be savior in mild ARDS. It can avoid intubation, it can reduce the ICU length of stay, the patient will not go to the invasive mechanical ventilator. All these advantages were seen in the initial studies, but the benefit was limited to only mild ARDS. Then we have few meta-analysis which confirm that NIV is not universally effective in ARDS. Best evidence supports the use of NIV only in mild ARDS, especially if we use the interface like helmet. The helmet is more tolerable and can deliver better pressures and there will be less amount of leaks. So helmet is the best interface among all the interfaces available for non-invasive ventilator. Intubation should not be delayed if NIV fails. That's the message all the meta-analysis have highlighted. So for examination, remember that NIV reduces the intubation rate, definitely, but not the mortality in ARDS. All the meta-analysis show that there is no mortality benefit of using NIV in ARDS. The lung safe study, you should remember, as far as the NIV in ARDS is concerned. Lung safe study was the largest international observational study of ARDS, and it provided critical insight into how NIV is used in real world practice. It showed that NIV was applied in about 15% of the patients of ARDS, but failure rates were high in moderate to severe ARDS, and with delayed intubation linked to worse outcome. Now let's move on to a question here. What are the ARDS patients in whom NIV could be successful? As we have just seen in the evidence that the patients who have just mild ARDS would be better. So mild ARDS like PF ratio more than 200 are the best patient for NIV. Second type of patients are the ones who have hemodynamic stability. The pH is normal, metabolically also stable. You don't have high severity of scores, you are less critically ill. So you can do the Apache 2 or SOFA score to gauge the severity of illness. And if the severity of illness is less, likely your NIV would be successful. And there are so many other predictor of success, like if you put the patient on NIV, there should be initial improvement in oxygenation within 1 to 2 hours of trial. That is also a predictor of success. Now, that is the reason you should be carefully select a patient, and when you have put the patient on an IV, you should be monitoring them closely for likely failure. That's very, very important, because NIV failure rates increase significantly with ARDS severity. As I was saying, that it has been used for moderate to severe ARDS, but the mortality was very high. Approximately 30% in mild category of ARDS, they fail NIV. 50% in moderate category of ARDS fail NIV. And 70% of ARDS patients fail NIV if they are of severe category. So therefore, avoid using it for patients who have moderate to severe ARDS. Other predictors are also defined of NIV failure, like if the patient is very tachypneic, respiratory rate more than 30, or tachycardic, or acidotic, low pH, less than 7.2 or 7.1. A patient is not cooperative, altered consciousness, and a patient who have high severity score, high Apache 2, high SOFA score, or multiple organ dysfunction, then definitely they are the predictors of high failure of NIV. The rates of failure will be very high, more than 70-80%, and in that case, definitely you should consider early intubation. Another thing is which has been observed with NIV in ARDS patient is that patients may damage their own lung. That is called patient self-inflicted lung injury, PSILI. This is a type of lung injury and it worsens the ARDS. So what happens is that patient, because of high inspiratory drive, they inhale a lot of air, increase their own tidal volume, more than say 10 ml per kg. And as you know that in ARDS, the baby lung, which is uninvolved lung, is still working, a functional lung, will get damaged by this much large tidal volume. And on an IV, the pressures, we are giving pressures also, right? So that will worsen the baby lung and cause a lot of volutrauma, barotrauma, and that can lead to something called PSILI, patient self-inflicted lung injury. So that should be avoided. Okay, so that such patients should be intubated early. So the practical approach at the bedside would be, first, you should select the patient carefully with mild ARDS, cooperative, then closely monitor them and apply the proper interface, and put the patient on comfortable CPAP setting. So little low CPAP, 8 to 10 centimeter of water, and most importantly, as I said, monitor them very closely for signs of an IV failure and reassess them after 1 to 2 hours. If there is no improvement in signs of acute hypoxemic respiratory failure, intubate. Don't delay intubation. Okay, so always reassess them after 1 to 2 hours of application of an IV. And if there is no signs of improvement, definitely don't delay, intubate, because the mortality in such patients is very high. So the key learning pearls are that NIV is not a panacea in ARDS. Success hinges on patient selection. So for an IV success in ARDS, patient selection is key, and it is a trial, not a therapy, not a definitive treatment. Avoid delayed intubation by monitoring closely for deterioration. As I said, the failure rate of NIV depends on the severity of ARDS. As I said, don't even think of applying it in moderate to severe ARDS. That is the PF ratio less than 150. Better to go for intubation. Okay, but people do not listen. They don't look into data, and they just continue, and that worsens the mortality, and that causes PSILI. So please avoid it. Avoid NIV. So non-invasive ventilation is generally discouraged as a first-line treatment for moderate to severe ARDS due to high failure rates and potential for increased mortality caused by PSLI and other complications, and it is primarily considered for very select patients. So this is my takeaway for all of you guys who are going to appear for exam. And in comment section, you can discuss this case in a 45-year-old with pneumonia-induced ARDS, PF ratio is 120. What would you do? Would you try NIV or intubate immediately? What's your take on this after listening to this presentation? What is your take considering all the new guidelines and major articles like lung safe study? And that's all. So read well and keep yourself informed well by all the latest evidence and do the best for the patients. Thank you so much.